Thank you very much. And it's a real pleasure to be here with you and with this excellent lineup of speakers. So I'm going to talk about the social burden of AMR, and really thinking about, first of all, our drivers of AMR and um, the need for a societal response to antimicrobial resistance. Like the last speaker, I'm primarily going to talk about antibiotics and antibiotic resistance in this talk. Um, I'm going to talk about the way that, so as a driver of AMR, antibiotics, but also talk about the burden of antimicrobial resistance. And that was just alluded to in terms of that uneven burden, and what shapes that, and what shapes the way that we think about that burden, shapes what we decide to do about it. And so then thinking about what interventions we do for AMR, um, uh, will be shaped by the way we think about the nature of the problem. So really, I want to be kind of proposing that we think about this as a social problem as much as it is a clinical and economic problem. So social science in antimicrobial resistance is growing, but is much, much smaller than you can see in this analysis comparing with other infectious diseases and climate change research and so on. So AMR is in the green at the bottom. That's up to 2018. It has grown since then, and there is actually now quite an active community of social researchers across lots of different disciplines doing work on antimicrobial resistance. When we think about antibiotics in particular, we've seen quite a lot of research that has the premise of the research questions has been, how do we change people's behavior around telling them to stop using antibiotics? How do we convince people that they shouldn't just be buying them over the counter, or they shouldn't be using them so often in hospitals and so on. Our analysis of this, and this is primarily analysis in different low middle income countries, is that it's not as simple as that. You won't be surprised to hear that just simply telling people to stop using antimicrobials is in itself not going to be effective. And in part, that's because the antimicrobials have become very entangled in our systems. One way to look at that is the way that they have become kind of a quick fix for things that are more systemic. So in the absence of really good quality care, we see antibiotics being prescribed and purchased. In the absence of really good hygiene, they're used prophylactically, and they're used presumptively. More broadly, antibiotics being used to enable productivity, to get people back into work, to enable you to not take a day off work if your child or yourself is sick, trying to use antibiotics as a quick fix for those scenarios, and also a quick fix for inequality. And we'll come back to the issue of inequality, and we're thinking about actually the burden of AMR itself. So this becomes a bit of a cyclical issue. Another way of looking at that quick fix question is also thinking about antibiotics as infrastructure, so as part of our infrastructure. So if you think of infrastructure as being the things that sort of disappear by definition, the things that we just take for granted, the things that are part of our world and enable us to go about our business in the way that we do, one might say that for many decades, despite some of the calls of concern about antibiotic resistance, actually we've really taken them for granted, and we've been pushing them forwards in terms of increasing use and increasing reliance on them, and so that they become part of our infrastructure materially. So, for example, the layouts of our buildings, laboratories, ward hospitals is made possible by the presence of antimicrobials. They're also part of our relations. They're part of our ability to have productive systems, both for animal production and humans being able to be productive in the way that we are, is heavily reliant on pharmaceuticals, including antimicrobials, for us to continue in the ways that we do. And they're also part of our political infrastructure. So antibiotics becoming part of the way that we organize our societies. This means that if we go back to that picture of antibiotics being a quick fix, it's not as simple to say, okay, we've got antimicrobial resistance, let's just take away the antibiotics. Then the system that has become reliant on them will really, really struggle. So it's not as straightforward as saying we just need to remove them. We need to recognize our interconnections within our wider systems. And so what we can see is that with the advent of antimicrobial resistance, we get kind of a moment of inversion where that infrastructure is made very visible, and we suddenly realize that antibiotics are everywhere and we are widely reliant on them. The question then becomes, what do we do about that? And the research that we have reviewed from the social sciences suggests that it isn't as simple as saying, well, let's just ask everybody to stop doing it, that these things are they've become entangled with our whole progress as societies and interconnected societies and globalization, such that they are part of how many parts of our interconnected world works. So to deal with AMR and to deal with antibiotics, we have to look at that entangled system. I'm going to move tack then. So that's thinking about antibiotics as a driver of AMR. If we think about AMR itself and how that is shouldered, we often think about that as a microbiological problem, as you can see on this very nice figure showing NDM1 spread. And we also think about AMR as a clinical burden, which was just introduced by the last speaker. This is the Gram analysis that was published in 2021 of the 2019 data, or the 2019 estimates. And so thinking about that as it is different diseases that are and with mortality associated or attributable with AMR. And as Dame Sally said, the commission that she instigated that was commissioned by David Cameron really showed the huge economic side of antimicrobial resistance. And this has been really powerful in recent years for communicating the size of the problem. And as you can see, this is projected to grow into the future. So we can see this microbiological issue, clinical issue, and an economic issue. And what I really wanted to propose today is that we also think about this as much as a social issue, and that there are multiple different dimensions of that. One dimension is the one that we've started to hear about more often, which is about that uneven burden, that it is shouldered unevenly in different places. So this chart shows how the burden in sub-Saharan Africa, specifically Western sub-Saharan Africa, is huge when you compare it with, on the right-hand side, Australasia. And this is because of the absolute numbers of people with infectious diseases, a proportion of which is drug resistant. So really, this is pointing our attention to the need to do all of the things that Dame Sally was saying about prevention and water and sanitation and basic infection prevention control, as well as vaccine access and so on, so that we aren't seeing that that burden that is primarily driven by the amount of infection in particular places. And you can see that, that difference between men and women, for example, the difference that was just introduced by the last speaker by ethnicity. So there's a number of different areas that are signaled by that kind of the population distribution of AMR, both between countries and within countries. And tracking that is obviously really important. But there's also elements of the social burden that are about how societies have to change or will end up changing as a result of having AMR. And this is an area that has not really been given equal attention. What do we need? What do we need to plan for as a society in a given country or as a global world in a world with antimicrobial resistance, we can take measures to try and avert it. But the other thing we learn from climate change is that we can't only look at mitigation strategies, we also need to look at adaptation. And that area really has been given less attention amidst the important areas of counting, surveilling, and making an immediate response. Our longer term response needs to include recognising that societal change. But there's also a really important area which is around the lived experience of antimicrobial resistance. And we often see when people are talking about AMR, the social side being about the drivers of AMR and trying to get people to stop using as many antimicrobials, for example, and doing better hygiene. But what happens when you actually have AMR? How is that experience distributed? And who is it who shoulders that experience? And then finally, in terms of who shoulders the interventions, I'm just going to read you a very brief excerpt from a paper that we did some research in peri-urban Thailand about bedridden patients who went on to get antimicrobial resistance. And so our teams were visiting patients who were at home or moving between home and hospital and understanding what life was like for them and critically their carers. So in this vignette, Aunt C welcomes us into her sister-in-law's home. She's been waiting for us, and we're working with the local community nursing team to learn about the experiences of people living with antimicrobial resistance. Amidst boxes of dialysis solution and the vestiges of what must once have been a beauty salon, we find Uncle T lying on his side with his back to the door. A big man in his 60s, not long ago able to drive a small truck for his living, in this peri-urban area near Bangkok, he now closes his eyes as if wanting to cut himself off from the world. The pair, now staying with Uncle T's younger sister for support, are exhausted from the ordeal of the past couple of months. First hospitalised for a month at the provincial hospital after a herniated disc caused Uncle T to lose feeling to his lower body, he was then referred to the regional hospital, where he remained bedridden for another month. Aunt C has put her own work on hold to look after Uncle T in a health system that, while attempting to provide universal health coverage, also relies on a family to deliver care. In his time at the regional hospital, Uncle T developed painful bed sores, and by the time he arrived home, his sister was so concerned with the size of these sores that she called the nurses at the local health centre for help. But the size, bigger than 2 palms of the hand, was too big for even them to manage, and they asked for him to be sent back to the hospital. But the hospital were unable to see him until his return appointment date, which left his wife and sister in a conundrum, having been told to help themselves. Aunt C explained to the nurse, "I was thinking for a long time whether I should call you or not, but I couldn't do anything else, so then I called." And the nurse cleans up the sore as best she can and leaves behind some cleaning kits. But then Uncle T's worsening condition led to another readmission, after a couple of days, with his wife following him to provide care at the hospital. In the course of his stay, Uncle T developed an infection which turned out to be drug-resistant. Visiting him on the ward in the zone allocated for AMR cases, we found him looking thin and depressed. His wife explained the events leading to his infection, which appeared to have been introduced with a Foley catheter. Now she was responsible not only for caring for him on the ward, but also for caring for the drug-resistant microbes that could be spread to other patients. The doctor said to me that Uncle is infected with a very lethal and dangerous germ, and that I needed to use all the things provided here before and after touching my husband, and she signals to a box with a gown, gloves, a bottle of alcohol gel that sat next to the red label AMR at the foot of Uncle T's bed. Aunt C sighed. It was hard to follow this advice. Caring for her husband did not align with the wearing of gowns and gloves. After a few more days, Uncle T was not able to survive the infection. 3 stays of a month each in hospital had drained him and his closest family. Caring for drug resistance is a burden shouldered not only by the health system, but by the family, and often invisible burden in a setting where, despite efforts of universal health coverage, many still fall through the cracks. So that excerpt is from work that we've done in Thailand, but that's not unique to a low or middle income country setting. We do hear stories across the world, including in the UK, where people continue to struggle with living through antimicrobial resistance. We also have been doing work in Uganda, in rural Uganda, where we've been looking at the burden of drug resistance, but also the burden of shouldering interventions. And here we've seen how the way that people are asked to shoulder interventions for antimicrobial resistance can compound the inequalities that they already face in the exposure to these drug-resistant infections in the first place. And we've written about this in a couple of papers. I won't go into the details just due to time. So thinking about that uneven distribution and how that compounds inequalities, we can see that across lots of different settings. And here we were looking at some of the factors in cities, particularly areas where you have high numbers of informal settlements. And the number of people living in informal settlements around the globe is now absolutely huge and growing and set to increase. So we really need to be looking at how the people who we're expecting to shoulder the burden of interventions and to do the cleaning and to do the sanitation and to stop using the antibiotics are the same people who are most vulnerable to the infections in the first place. I think it was really, really good to see in the political declaration of the high-level meeting that Dame Sally was introducing. There are two key paragraphs about that social burden that describes the vulnerabilities and the realities for people who are already facing socioeconomic challenges and financial hardships that can be furthered by that burden of drug resistance. So then there are many questions arising from that about what to do with for antimicrobial resistance. But I suppose one of the key things from the research from the social sciences is that we can't shoulder that entire burden of fixing AMR on individuals. And you can see in this picture an example where our lady there is she's got her baby strapped to her back and she's going to be dealing with AMR with mops and tools and so on so that she can stand in front and protect those medicines that are stacked behind her. And we see the slogan about fighting AMR. But the fight needs not to be just shoulders on the burdens of the most vulnerable who are already struggling, but we need to be seeing our shift in focus to how we locate where those interventions need to be. This requires a societal change. It requires structural changes to prepare for life with antimicrobial resistance, with growing antimicrobial resistance and protection for those who are most vulnerable. And one way that we can think about this, which also borrows over from climate change, is the idea of a just transition. How do you plan to transition to a future with reduced reliance on antimicrobials without further burdening those who are most vulnerable and compounding inequalities? How do we measure this social burden and ensure that it's going in the right direction and make legible those aspects of the social burden that really matter to people who are experiencing AMR, as well as those who feel at risk of AMR spreading. So I just wanted to make acknowledgements to our teams. A lot of the research that we have done has been funded through a Antimicrobials in Society research project funded by the ESRC, but also the Just Transitions project that we're doing is with the British Academy. So I just wanted to flag those. And then our new network on interventions and planning interventions for AMR is funded by the UKRI, and that is called Impact AMR. Thank you very much.